webinar on our website fairly soon as well, so you'll have another opportunity to go back and have a look at it. So now let me just tell you a little bit about our program today. With the explosion of smartphones and apps and social media, people are increasingly seeking and finding health information at their fingertips. In fact, one report, which is a few years old now, found that 1/4 of users were using their cell phones to get health and wellness, fitness, or nutritional tools. And for those of us working to promote health and wellness, it's important to figure out how we can best use this technology to reach the public with accurate and useful information and tools. Connecting people through their mobile devices can potentially make it easier to extend the reach of initiatives or to target interventions to select populations, and also to get instant feedback on what's working and what isn't, in addition to all of the evaluation measures that can be collected. So today we're going to hear about the latest in the innovative and emerging field of mobile health and how it's being mobilized in British Columbia. We've left time for discussion at the end of each presentation, so again, we encourage you to ask questions. Have a look at that little box. But before we start the webinar presentations, we'd like to start with a question about you. We're going to put up this poll and post the results. If you see that you fit into more than one of the categories, please just choose the one that best fits for why you're joining us on this webinar today. So Brenda, put up the poll. Wait for a couple more seconds here. Well, that's interesting. It's all of the above wins, 58%. Yeah, by quite a margin, along with those who are interested in mHealth and best practices, and as well as the carrot reward. That's great. Good. Well, let's get going. And I'd like to introduce our first speaker, Dr. Emily Sito. Emily is an assistant professor at the Institute of Health Policy Management and Evaluation at the University of Toronto. Her research interests include the development, evaluation, and implementation of mobile health to facilitate patient self-care and clinical support for chronic disease management. Welcome, Emily, and please go ahead with your presentation.
Thank you very much, Mary. So I'm honored to have been asked to speak today, and I'm very much looking forward to hearing more about the Carrot Rewards app as well. Next, please. So I've been allotted 20 minutes, and I'm going to try to briefly cover first why use mHealth at all, then talk a little bit about the current state of mHealth and provide a case study of a heart failure app that I've been working on. And finally, I'm going to give some thoughts around the future of mHealth. Next, please. So this is Martin Cooper, who co-created the first commercial mobile phone in 1973. And this phone weighed 4.4 pounds and had a hefty price tag of about $4,000, which is equivalent to about $10,000 today. Next, please. If we fast forward 24 years, we get to the release of the very first Palm Pilot, which was in 1997. Next, please. In 2005, the term mHealth was coined by Robert Istepanian. And there's lots of different definitions out there right now about what is mHealth. But personally, I like to think of it very broadly as the use of mobile communication devices for, excuse me, for any health-related activity. Next. So just a mere 10 years after the introduction of the Palm Pilot, the iPhone was launched. And what's interesting is that almost 10 years later now, the iPhone looks remarkably the same. Next. But what has changed are really the applications. So the iPhone 6 has now a health app that provides a dashboard for your health and fitness data. And it also has now a tool for developers called HealthKit, so that apps can be built that feed data into the health app. Also available now is the Apple Watch with built-in sensors enabling monitoring of pulse rate and physical activity. Next. This is a graph from the Pew Research Center showing the trend of cell phone ownership with time. In the US in 2014, the cell phone ownership was about 90%. What is interesting is that in low to middle income countries such as South Africa, it's about the same penetration. And the ubiquity of these mobile phones has really enabled them to leverage them in some very novel and impactful ways, including things such as HIV treatment. Next. In fact, mobile devices have become so ubiquitous around the world that of the 7 billion people on the planet, about 6 billion own a cell phone, which is actually much more than those who own a toothbrush or even have access to a toilet. Next. However, there are differences in smartphone ownership between countries. In 2014, there was about 64% of adults in US who had a smartphone, but there's much less in other countries, such as in South Africa. Next. What is particularly interesting, especially in the context of healthcare, is that according to a Deloitte study, those over 55 are now the fastest growing segment of the smartphone market. So basically, there's a lot of people with cell phones out there, but do they use it for mHealth? Next. So data from 2012 found that about a fifth of smartphone owners have a health app currently. Next, please. But not surprisingly, most popular types of health apps are those for exercise and diet. Next. While some people use health apps to monitor physiological parameters related to chronic disease management, such as blood pressure and blood sugar monitoring, they're still really not that common. Next, please. So there's no shortage of health apps out there. There's over 165,000 apps right now. And as you can see here, the majority of these apps, perhaps not too surprisingly, are for wellness management. Next. However, only 36 apps account for nearly half of all downloads, and 40% of all apps have fewer than 5,000 downloads. So a lot of these apps are not being used because, frankly, a lot of them are really kind of badly designed or not useful. So how do consumers choose a useful app? First of all, it's helpful if the app is from a trusted and recognized institution. For example, we've worked with the Heart and Stroke Foundation. It's also been found that retention rates are higher when physicians prescribe apps. Finally, especially for chronic disease management, the app is usually most beneficial if it promotes self-care and it's also linked to clinical care. So now I'd like to present some of my research aimed at improving both self-care and clinical management as a case study. So Medley is a platform that we developed aimed to help manage complex chronic conditions, including situations when people have multiple chronic conditions. Specifically, there are modules for heart failure, COPD, diabetes, hypertension, and chronic kidney disease currently. For all conditions, the goal here is to empower patients for improved self-care while also providing alerts and additional patient information to clinicians for decision support that they normally would not have. Next. Medley consists of an app that the patient uses at their home to send information to a server where algorithms automatically send self-care feedback to the patient and alerts when necessary to the clinician. The clinician can then contact the patient to provide education or other actions such as medication titration. Next. Due to my limited time, I am going to just focus on our heart failure module. So here's a picture of the kit that the patient receives, which includes a Bluetooth or wireless blood pressure monitor and weight scale, as well as the mobile phone with the Medley app. So the patient records blood pressure, weight, and symptoms daily, and automatically this information gets sent to the servers, and there's self-care feedback that gets sent back to the patient. And as I mentioned, the clinician gets an alert only when necessary. Next. Here's some example screenshots of the Medley screens. The first is the homepage of the app, which shows what readings are necessary to take for the day, and it gives a current status at a glance. The second picture is the symptom screen, which enables patients to answer simple yes or no questions. And finally, I've shown a screen for looking at trends in a graphical format, such as weight. Next. Here's an example of the alert that can be generated based on, in this example, a weight gain. And so here the patient is instructed to follow their doctor's instructions to take an extra dose of Lasix and to follow a salt and fluid restricted diet. Next. So alerts also get sent to clinicians, and there's two mechanisms. One is through email, where they get all the information about the patient through this email, including the patient's phone number, which they can just click on and quickly phone the patient. There's also a dashboard that we've created where the clinician can log in to look at all the alerts as well as to see all the patient data. Next. Medley was built at the Center for Global eHealth Innovation in Toronto. I'm not going to go through too much in detail here, but it was developed over many years with a multidisciplinary team of people using an iterative user-centered design and agile development process. Next. So using an earlier version of Medley, we conducted a randomized control trial in the heart function clinic at the University Health Network. We had 100 patients with heart failure who were randomized into the control and intervention arms, and they were followed for 6 months. We used a mixed method study design to figure out if the intervention was actually doing anything. Next. In a nutshell, we found that quality of life and self-care improved, and using a subgroup analysis, we found that BNP, which is a biomarker that gets released in the blood when the heart is working too hard, improved, and also the left ventricle ejection fraction improved in a clinically and statistically significant way. Next. We were also really pleased that there was an extremely high adherence even at 6 months, and you probably have heard that a lot of people stop using apps after the honeymoon phase, which is often just a few weeks or a couple of months. On average, patients completed all measurements even at 6 months, 5 days a week. And this included elderly patients, such as our eldest one, who was 88 years old, who really brought his kit even with him to Florida from Toronto for several months. And he was monitored while he was in Florida by his Toronto cardiologist during the winter. Next. So we found that patients felt more responsible and accountable, and it was encouraging that they modified their behavior in a positive way due to the app. They also felt that they were participating in trying to keep up with their health. Next. The clinicians found that the telemonitoring system was useful for early detection of decompensation, improved communication with patients, and it also allowed for teachable moments, which is times when patients can actually learn because the information can be applied at that time of need. Next. We've conducted a lot of clinical trials using Medley or previous forms of Medley in various service delivery models, including primary care, specialty care, and home care nursing settings. And we learned a lot of what works and what doesn't. Next. All these clinical trials have actually led our team to develop an advanced case of a well-known chronic condition in our community that we call pilotitis. And in fact, I've really kind of lost track of how many grants we have written in, to try to support our pilots, some which have been successful, some which have not. Next. So if I were to define some of the causes of pilotitis, at least from my own experiences, they would include a lack of sustained funding model to support long-term programs. There's also misaligned incentives for healthcare institutions to implement these kind of innovations. For example, there's currently no financial incentive for hospitals here to even reduce the number of hospitalizations. There's also a lack of reimbursement methods, such as for clinicians to get paid for phone calls or emails to the patients, even if this is maybe the best way of interacting with their patient. There also has been some big studies that have found no improvements in similar technologies and interventions. However, it's important to consider that in almost all of these cases, it can be attributed to poor intervention design and or study design. Finally, there's a lack of knowledge on how to integrate these innovations into our very complex healthcare system. Next. Luckily, we are in a period of what I call remission, and I'm careful not to say cure because I'm sure we're going to be afflicted by this disease for many of the innovations that we're working on right now. But it really was a case of the stars aligning for us to be launching a heart failure telemonitoring program within the next couple of months at the University Health Network in Toronto, and also an analogous chronic kidney disease telemonitoring program here. So I don't have time to go into all the details, but there are many factors that came together to overcome the many barriers for long-term implementation. Next. In terms of sustainability of the programs, there are a number of things that we have working for us. And first, there was no additional clinicians that we're adding to the mix, and this is really important so that we keep our costs down. It's also advantageous that the clinicians involved are already part of the care team, and this is important for logistic reasons and also that trust that has already been formed between the patients and the clinicians. We also have no need for technicians to visit the patient's home to install anything, which is, again, a cost savings. And we could also redeploy patient telemonitoring kits as patients exit the program. Next. We're also trying to make sure that the programs are scalable. For one thing, the patient kits are really inexpensive because they're really based on mobile phone technology. We are creating a second tier as well, where there'll be a manual entry version for patients to enter their data themselves, so they could use their own blood pressure monitor and weight scale. And we're also creating a Wi-Fi option so that we don't have to pay for data charges. The phase after that, or the third tier, would be a true bring your own device model. And this would essentially mean that there are basically no cost for equipment, and there's no real reason for patients to ever get off the program. Finally, we hope to spread this to other sites, and of course we would capitalize then on economies of scale. So I think I've got a few more minutes, and I'd like to provide some thoughts on some future trends on mHealth. One of the biggest areas of mHealth advancements is in sensors and wearable devices, such as activity monitors. And it has been found that connecting sensors and wearables to apps actually drives use. Next. There's also many continuous sensors being developed, including wireless ECG patches, which are basically like a big Band-Aid that can be worn for days at a time in a very non-obtrusive way, and also wireless EEG headsets that can be worn under a hat or a cap to follow patients with, for example, mental disorders while they're living their daily lives. Next. There's also a number of researchers trying to find a way to have non-invasive methods of blood glucose monitoring, such as through a watch-type system and even contact lenses. So these are still in development and testing phases with some promising advancements, although several past products have not been successful, including the GlucoWatch shown here, which was found to have inaccurate readings and actually a problem of burning patients' skin. Next. What is also coming up are implanted devices, which may not be as far off as many people may think. For example, there's been a lot of research in the artificial pancreas. It's a closed-loop system that a continuous glucose monitor uses to send data to a controller, such as a mobile phone in this case, and then algorithms reside in the mobile phone that determine the dose of insulin that needs to be administered automatically by the insulin pump. Right now, the continuous glucose monitor involves an electrode that's inserted under the skin that needs to be replaced every few days. But there's research in stage 3 clinical trials right now on a fully implantable continuous glucose monitor that can be left for up to a year within the body. Next. Gamification is another big area of mHealth. This is an example of an app that we helped develop called Less Than 30 Days, which was developed in partnership with the Heart and Stroke Foundation. So it incorporates gamification by providing virtual rewards. So the premise of this app is that bad habits can be broken and good habits can be replacing them within less than 30 days. So after an initial assessment of the person's risk for cardiovascular disease, daily challenges are presented based on those risk factors. Next. This is an example of another app for diabetes monitoring that's called BANT, and it was specifically tailored for adolescents with diabetes. We conducted a trial here at the Sick Kids Hospital in Toronto, and it incorporated a reward system where the kids would be able to collect rewards based on positive behaviors, and they would be able to redeem them for iTunes apps and music. It also incorporates a leaderboard where the kids could compete for the top spot. Next. There's also a trend towards incorporating social networking, which was also included in the BANT app that I mentioned, where the kids were in a community and could post messages to each other. Next. From a small pilot trial, and actually right now we're doing a larger randomized control trial, we found that the gaming and the social networking features seemed to work, and that one of the main findings was that kids tested their blood glucose 50% more with the app than they did before using it. Next. So there's been a lot of interest also around big data and how the big machine, which integrates the various sources of big data, can be used to improve diagnosis and treatment and ultimately to improve health outcomes. I think there's a big role that mHealth can potentially play here in feeding data into the big machine in all the areas of sensors and remote patient monitoring, as well as in public health. There's even apps now for you to get your genetic code, which can be used to feed into the big machine. Next. So I wanted to wrap up now by summarizing what we've learned over the past really decade in mHealth. Perhaps the most exciting and challenging aspect of mHealth is that it's evolving at an incredible speed. So you really have to be prepared for your innovations to be obsolete. We also found that what's easiest first is probably what makes most sense. And so there's lots of low-hanging fruit to be had in mHealth. And really we can capitalize on some of the new behaviors that mHealth is creating and the new technologies that are coming online. It's also important to design for the target patients and clinicians. And part of that is to follow the KISS principle or keep it simple. And really we found that the simpler the better, perhaps even the less features the better often. And finally, technology is usually the easier part in terms of all of this. What's really hard is the implementation of it, including trying to find funding, trying to go around privacy concerns and workflow issues, and just to try to keep it on, to keep it going long term. So next, please. What I didn't want to do is just acknowledge that, you know, all this work that, or some of the work I presented has been only possible through a large group of people that I work with, and as well as we have a lot of clinical partners and project funders and industry partners that really helped make this possible. And I think I should have a few minutes for questions at this point in time. Thank you.
Absolutely. Well, thank you, Emily. That is absolutely fascinating. I hadn't realized there was just so much going on in Ontario in what you're working on. I just want to remind everyone that you can post your questions in the box at the bottom of the screen there. So please, if you've got questions for Emily, just type them in and we'll try to answer them now or perhaps at the end of the session as well. Perhaps I can get started. I wondered, I mean, there's just such an array of potential mobile technologies. Has anybody been doing any analysis of, say, the economic analysis of potential savings to the healthcare system in terms of being able to utilize some of these technologies?
Yeah, so with all these trials that we've been doing, we always have an economic analysis component of it. And what's interesting is that, you know, of course it's very variable depending on the application for the app, right? So what target audience you're trying to target as well as what the app is supposed to do. What we've been finding, especially around chronic disease management, is that everything gets swamped out by hospitalization, right? So if you can reduce the number of hospitalizations, usually that is what's driving the cost savings in the healthcare system perspective. It's also quite interesting kind of looking at economically, you know, who should be paying for the apps. And again, it depends also on the type of app, but certainly in terms of those ones that we've been developing for chronic disease management, there's no expectation that the patient ever pays for it. And so, you know, having that again is a bit of a barrier for who pays for it. And again, if it's a healthcare system, then you need to show that there's some kind of cost savings. And again, that's usually around hospitalization reduction.
Right, yeah. You also mentioned the challenge, and I would certainly agree in terms of reimbursement arrangements so that healthcare professionals who are at the other end of some of these technologies to support the patient can get reimbursed for their time and effort. Has there actually been any pilots where you've been able to do that?
Well, for our pilots, we actually had to reimburse our clinicians. For example, in a home care nursing pilot we did, there was no funding. I mean, they couldn't bill for making phone calls, for example. And so we had to pay through it through our study funds, which obviously is not ideal and not sustainable. But I do see that there's ways around it, and a good example is around telehealth in terms of the traditional kind of teleconferencing that's been done. So, a few years ago, there was no way to bill for that. And so they opened up a billing code. And I see that as, a good indication that policy can change, and we just need to kind of move with the times and to push that forward so that there are ways to bill for these kind of type of new services, which may make a lot more sense than the traditional method of bringing a patient into clinic every time, they want to talk to them. So I'm optimistic about that. I think it just needs to have to align with policy.
Right. Yeah, no, lots of opportunity for change there. And I guess, I don't know whether you've had a chance to look at any of the, the free health apps that are available, whether you have been able to evaluate the efficacy or content of any of those. I mean, how do we differentiate between ones that actually have some positive impact versus those that quite honestly don't really make a difference?
Yeah, there's been a lot of studies looking at that, and we try to kind of look at that as well. But again, the quality of the apps are all over the place, and especially when you look in, as I said, there's 165,000 healthcare apps at this point. Most of them are not being used, and most of them are just not well designed, frankly. And so it's really hard to look at efficacy when you're trying to do that, because honestly it's not being used. So it's usually a one-off thing where you're looking at specific applications and doing some sort of trial on that, or just following and evaluating that particular app. So again, it's so highly variable that it's hard to make a blanket statement. I mean, you really have to have a well-designed app that has a focus on what it's trying to do and what the endpoint is, and then to build in those metrics to actually evaluate what you want as an outcome.
Good point. Now, Drona has a question here. He's saying, back to basics, these technologies are not affordable to most people in the population. Whereas the mobile phones are universal even in developing countries, in Canada, having a mobile phone is still a luxury. Shouldn't the researchers and companies work on making the technologies affordable?
Right, and I think that, the evidence is showing that most people have actually a mobile phone at this point in time. Maybe not necessarily a smartphone, but even that, the majority of people are starting to have smartphones. And so as these technologies, they're getting cheaper and cheaper every year, and starting from like $4,000 when the first phone came out, cell phone came out, to now you're looking at, you could get one for $100 and even less if you have a data plan embedded in there. So again, the data plan is partly an issue, and in Canada, data plans are kind of notoriously expensive compared to other countries. But again, I think it's really becoming quite ubiquitous, and if you're looking at who should be paying, maybe we need a model where there is some reimbursement from the healthcare system if, in fact, these technologies are helping reduce costs into the healthcare system, right? And again, apps are relatively cheap. The technology that we're talking about in terms of the wireless blood pressure monitors and weight scales, they are kind of going down in price to almost equivalent to those of without being wireless. So I do see the trend of cheaper and cheaper devices. The apps do cost something to create a good app, but again, that's nothing compared to what some of the other models would cost, and I think that's the key.
So do we have stats on mobile phone or smartphone utilization in Canada?
There probably is something. It's always lagging, which is the problem. I would think it's very close to what's in the U.S., which is about 65 or 64% penetration at this point in time.
And Mimi is asking, is there any app that can help people with chronic kidney disease, and any evidence that these apps have made a difference specifically for chronic kidney disease?
Right, and I think with chronic kidney disease, again, one of that's a very kind of a serious condition that needs the input and constant input with clinicians. So it has to be tied to the healthcare providers. So it's not just a standalone self-care app. And so we have developed an app ourselves for chronic kidney disease, and has gone through pilot showing some really interesting results, and we're going to do a randomized control trial on it shortly. But it has been showing that, for instance, blood pressure is decreasing with the use of the app. And again, the sample size wasn't big enough to look at harder outcomes. But with our RCT, we're hoping that we can find, really concrete evaluation evidence that it does work. But again, I think the key there is it has to be hooked up to some kind of healthcare provider so that the information is getting fed back to them, and they can work with the patient and use the app as a communication vehicle almost.
Great. Well, thank you, Emily. We're going to move on to our second presentation now, but we anticipate there'll be time at the end for further questions to both of you. And so we'll stay on the line, and it is a absolutely fascinating issue that you're involved with, Emily. Thank you so much.
Thank you.
I'm going to move on now. Now, unfortunately, Regan Hansen was unable to join us today, but we're very pleased to welcome Kristen Patelski. Kristen is a Senior Manager of Business Operations and Digital Strategy on the Health Engagement Unit at the Ministry of Health of British Columbia. She has played a leading role in the digital strategy supporting the province's Healthy Families BC, and she's been integral to the development of the Carrot Rewards app over the last year, and that's what she's going to share with us today, some of our initial experience with that as well. So welcome, Kristen, and please go ahead.
Thanks for the introduction, Mary, and I'm honored to be here talking to you all today about a project that I have been working on for the past 2 years called Carrot Rewards. Next slide. I'm going to start off this presentation by saying that Carrot Rewards started off as an idea conceptualized by a couple people involved in the project several years ago. This concept came to life due to an increasing need to find new ways where we could better connect with people about health information and influence behavior change for better outcomes. Quite simply, our traditional approach has been creating awareness or just hearing about the right thing to do, and that hasn't been making enough impact with the different types of user preference needs in an ever-changing digital landscape. So as a team, we knew that we needed to start looking at new approaches, and we were looking at things that could better present information and choices to help citizens make sustainable decisions without constraining their freedom, to be an effective solution that could cost little to nothing to test or implement, and also be an alternative to complex legislation and costly marketing. So from there, we began to look at some emerging trends, and there were really 3 that stood out to us. One being behavioral economics, and more specifically, the nudge theory. So using design choice principle and techniques to influence behavior change. Smart technology, so looking at the success of smartphones and apps that play a key role in the day-to-day life of an individual. And then we were really looking to private sector innovations, and more specifically around the loyalty points. I know that Ministry of Health, as well as the Public Health Agency of Canada, we've done a couple of pilot projects with loyalty point providers, and incentives have been a proven tool at influencing measurable consumer behavior changes. Fun fact here is that Canadians are actually among the world's most ferocious users of loyalty points, and on average, they do participate in 8 or more loyalty programs, so that was a real interest to us. Next slide. So what next? It was really about perfect timing for this project and a pitch from a company who said that they had an app for that. And they were offering us the key attributes that we were interested in. So what Carrot Rewards does is it capitalizes on using leading smartphone and app technology and the data intelligence that comes with it. So through the advanced technology, we can precisely measure performance, look at real-time behavior shifts, and the data that we get can help us build out detailed response models for our future planning needs. The app also uses nudge design choice principles and techniques that enable us to make small changes to the information activities in the app. It harnesses the popularity of loyalty point programs by rewarding citizens who participate in activities in the app. And through those targeted incentives, the app does leverage a simple pay-for-performance model where cost is only incurred once as the action has taken place. And lastly, the app itself has the influence and the credibility of government, NGOs, and prominent loyalty point providers that make the app popular and likable. So next slide. So it did take a village to develop the app. The BC Ministry of Health, the Public Health Agency of Canada, together with the private company Social Change Rewards, came together to create this platform. Social Change Rewards, they were the ones that really connected with the loyalty point providers and developed out this app that could be around this incentive model. Then we had the founding national NGOs, so Heart and Stroke, Canadian Diabetes, and the YMCA. And then from a BC perspective, the Ministry of Health wanted to bring in the BC Healthy Living Alliance to give the full complement of that health promotion perspective. And then we have 4 leading loyalty point providers as participants in the app right now. So Aeroplan, Scene, Petropoints, and More Rewards, which is Save on Foods here in Victoria. So next slide. So I'm going to introduce the app. As you can see, the Carrot Rewards is for a smartphone. A user with an iPhone or an Android can go to their app store, so Google Play or iTunes, to download the app. Once the app is installed or downloaded to the phone, the user will be taken through an onboarding process or registration where they will need to enter their name, age, gender, postal code, and loyalty points card number. After that is completed, the user will get some points, and then they'll be taken to their first offer. So next slide. So the app has been designed in the first phase to focus on what we call in-app activities, or what I like to call task cards, that are related to the topics of healthy eating, physical activity, mental health, immunization, alcohol, and tobacco. The task cards themselves have been designed as question sets, so there'll be about 5 to 7 question and answers within an app. A user will be taken through the flow, and then once completed, they will get rewarded points. And then the last screen of the question set is a key message or a takeaway for the user, and then a link out to a credible resource, website, or service to add that, to provide some added value. We have also designed out 2 health surveys, and they're based on the CMHS questions to get a baseline knowledge of users, and then we'll follow up at future dates with more surveys to understand or to test knowledge of the information that the user has received through the offer, so that we can start to better design the question sets and start looking at how we can segment specific topics to a population. We have also designed out some cognitive skill question sets that are focused on more around planning, setting goals, or that self-management reporting that do relate to some of the topics that I had just mentioned. So next slide. So like I mentioned, you can earn rewards for downloading the app, completing quizzes, and completing the surveys. One of the nice features about the app is that you can refer a friend. So the app has the functionality of inviting a friend. You can put in the email address. Once the email notification goes through to the friend, they have signed up or registered for the app, then myself, if I was the referrer, would get the points. And this is a great way for us to use a little bit of what we like to call earned media and sort of have that viral effect so that we can get more users into the app. And then the level of rewards varies depending on the activity. The users who, it's just the way the question set has been designed and the complexity of the technology of the app, but we can ensure that the users who engage regularly with the app will expect to see those tangible rewards quickly. So next slide. So performance and evaluation has been a key part in terms of the development of this. The evaluation has been built into the funding with the Public Health Agency of Canada, and Social Change Awards has actually hired behavioral economist Mark Mitchell. He's a PhD, and his area of focus has been in incentives with health behavior models, and he's designed out this performance and evaluation model that looks at our short-term, medium-term, and long-term objectives. So we're really trying to figure out, the knowledge, the attitudes, beliefs that a user has, and then as the app grows with different functionality, we're really hoping that we can start nudging people towards those small behavior changes, and so that's what Mark's going to look at. We have Heather Carter, and she's a consultant on us and a digital strategist that's working more specifically around the metrics, the weekly metrics of the app and sort of what is happening on a day-to-day basis. And I've been quite involved with her in trying to figure out how many interventions have been done, who's accessing or going to the app stores and accessing the app, downloading the app, and then what's sort of the conversion rates as we work through the first 3 weeks since we've launched. And then we're also getting support from a third-party validator. So Dr. Guy Faulkner, who's another behavioral economist and works through UBC, is going to be doing some further evaluation for us on the app. And then next slide, please. I'm going to fast forward to today. So like I had mentioned, just recently mentioned that we have just launched the app. It launched March 3rd, so we're pretty much into a month. We started out with some earned media. So essentially, people getting to the app wouldn't have known unless they got an email from their points provider or connected to one of our NGO social media channels, or may have heard about us through Social Change Awards and a little bit of PR to date. And we've only released emails to Seen and More Rewards, BC-based emails, that we've had 43,503 people registered for the app. In the app, the completion of offers, we've had 422,416, and that's coming in at an 81% completion and engagement rate for the app. So in our original projections, we had expected a 10% engagement rate, and that was based on the few pilot projects that we have done with loyalty point providers, and those were more of in the retail space. So like I had mentioned, us with Ministry of Health, we worked with Air Miles and did a little points promotion within Safeway stores a few years back, and we noticed a 10% increase in vegetables and fruit being purchased at point of sale. And then the Public Health Agency of Canada had also done an incentive with the YMCA and had noticed around a 10 to 20% engagement rate there. So with this, as a takeaway, we didn't expect the 81% completion rate or engagement rate, and we really do believe it's because having this on mobile, it's a really great way for people to quickly access and access the rewards and access the information, and that they're engaged with it. And then as the last takeaway from this, the interventions that have been released, like I said, have little links on the task cards at the end. And for myself, managing the Healthy Families BC website, I am noticing that we're getting high click-through rates from the app itself to the site, and we're getting about a 30% click-through, which is pretty high when it comes to people wanting to play in the app and they have to switch over to their Safari or Chrome or whatever their search engine is on the phone and be connected that way. So we're finding that, again, an app like this and the way it's been designed out, we're seeing some high engagement rates by the users that have signed up so far. Next steps for us, which we're just in the planning phase, is, like I said, we're in the in-app activities, and we'll be going into retail and tracking devices really soon. We're looking at connecting with the Health Kit app on the iPhone, and there's also another health app on the Androids, and we're going to be linking Carrot Rewards to the walking piece. So all the phones have an accelerator, and sort of through GPS, we're looking at rewarding people for the steps that they have taken, which is going to be a really interesting exercise for us, because we really did, our goal for this app was to not just be kind of an information-based in-app activity, but we wanted to see people doing you know, the things, the actual activities outside of their mobile device. And so we're looking really, we're really excited to kind of hear what those plans are, and we'll be hearing about that in the next coming weeks. So it's been only 3 weeks. We're in the really infancy stage. We're collecting lots of data, and we're really excited to learn more from the users in the app. So next slide, and that would be my question slide.
Great.
So,
well, thank you so much, Kristen. I want to add that for us here at the BC Healthy Living Alliance as a partner in this initiative, it's been very exciting to be involved in the development of Carrot. As you said, it's only been live for just a month. There's certainly been lots of challenges, lots of unknowns. It's amazing how many things get solved with some strategic thinking and discussion and number crunching with our partners. It's been great. We've got a couple of questions that I'd like to just ask you at this point. Jerry was asking, he's got an older phone which only allows him to have iOS 7, and therefore is not able to download the Carrot Rewards app as it requires iOS 8. So do you anticipate a time when Carrot Rewards will be available to us who have older phones?
Probably not, and the reason I say this is it's not just our app, it's the platform, or Google and iTunes themselves have been updating all their apps to a new operating system. So even if we think about our computers, as we start looking, you know, trying to look at new websites and stuff, a lot of those websites are not being accessible to old operating systems. So I think it's sort of the platform providers are trying to encourage us to, you know, upgrade to new operating systems. And so as you develop on an app, you kind of have to play to sort of those rules. So we can't work backwards. We always have to work forwards. So right now it's just on the iOS 8 and above.
Right. Yeah. Well, thanks. And Cheryl wonders, do you have to be over 19 to gain loyalty points?
It truly depends on the loyalty point providers. So with Scene, because in their terms of conditions, you can be as young as 13 to actually get rewarded through the Scene loyalty points program. So in terms of how we've had to set up the app, and in that onboarding process, the age does go down to 13 to accept the terms and conditions. But there will, through that organization, they have, you know, through their legal terms and conditions that the parents, you know, will have to work with the 13 or teenager to be able to sign up. So we have to play to those, and so it brought the age level down. But for the other points providers, I think the age requirements are 19 and above.
Okay. And Karen is asking, what is a click-through?
So the click-through is essentially going from one, so if there's a link in something, so you're on one website and there's a link and it's clicking to another website, that's called a click-through. So a lot of, if you're reviewing the metrics, that's a really important thing from a data perspective to look at, is seeing how many people or how much traffic is landing on a page, reviewing a page, clicking on the links to another either page or another website. And so we look at these rates, and you can look at them for various reasons. Within the app, we wanted to look at the click-through rates. So clicking from the app through a link to either another website resource or connecting to a service. We have our 811 call lines, and we're hoping that we can click, it's just an easy click to use your phone and call a nurse or a registered dietitian. So we're looking at these click-through rates and seeing, are people actually going outside of the app? And if they are, then we can start designing our interventions to really start driving people to our other credible resources that we have here in the province.
Right, and I know one of the click-throughs is to the BC Healthy Families website too.
Yeah, and that's been really important. Yeah, that's been important for us, just to make sure we spend a lot of time and energy with our subject matter experts to design, credible content on the website that I manage, and I wanted to make sure that people are going to the right resource because I know there's a lot of clutter in the digital world that they can get on health information. So we're trying to direct people to the right resources.
And now having been at this stage of the process with Carrot, and I realize it's still young, it's still lots of issues to be dealt with over the coming months, but do you have any advice to those who might be thinking about setting up an initiative such as this? Because I know that there's a potential that Carrot may in fact spread to other provinces.
Yeah, so just I think a lot of it, having a good project manager and a good, you need to have someone that really understands the technology when it comes to developing out the app because there's a lot of different areas that you have to think about. And so for myself, developing out the app, we did have to think about privacy. We have different privacy rules in the other provinces. And this company, Social Change Rewards, is actually, they live out of Ontario. And so they play with the federal laws, and we, BC, have specific privacy laws. So there's a lot of back and forth with our legal team and our privacy officers to figure out, with this new technology, and I'm going to admit that some of our lawyers and privacy officers are still trying to keep caught up to everything, that we're really trying to understand how that works. Then there's all the content behind the app, and it did take us, I think, almost 6 months to really figure out what was the content, what was the tone and language, and so going through that whole branding exercise and hiring the right people or working with the right people to write, getting all our subject matter experts in, there was a lot of back and forth, and so from a planning perspective, that having a good project manager in that sense was key. Then just even like the partnership relationship, so it's, like I said, it takes a village to build this app, and there's a lot of discussions going on, and so that was another process there that we really needed to work through and really come up with, what's the vision of this and what's the terms and conditions, and going through all that kind of messy discussions to create a successful app like this. And then lastly, from the the evaluation piece, there's so many things that you can evaluate with an app, or from the metrics itself. And so we really wanted to understand, what were our key objectives that we were measuring, so that we were very focused and making mindful decisions when we did receive the data from Social Change Rewards. So I think those are the key points that come up.
You mentioned privacy, which I know has been a big issue in the development and implementation of that, and actually Gail is asking, does the demographic information collected from the participants go to the business organizations for their promotion?
So the way that it works is Social Change Rewards does receive all the information, and they can't sell any of that information. It's only used for their purposes. How the partners work in that, from the loyalty point providers will get their, they need to know their card information so they can reward the points, and so the platforms speak to the loyalty point platforms. But for any other of the other partners, we get aggregated data. We don't know, we can't get behind the scenes and know the exact person and what types of questions they're answering and sort of what their activity levels. We're going to be receiving sort of that general population view. And it's great because if we kind of know, I think what's really key for us here is the postal codes and sort of the age and the other demographic, in the sense that I have a health surveillance team here, and so getting all that aggregate data, we can really take a look at the populations via the postal codes and start really understanding what are the health indicators and what's the areas that we kind of maybe need to start targeting to that cohort and start letting them, sort of increase knowledge and awareness and maybe some activities to a very segmented group. But everything to us, like I said, is coming to us aggregated, and under the privacy laws, nothing can be shared for marketing or promotional purposes. So it's a win for us.
Yeah. Now I want to come back and bring Emily back into the conversation, because we have a question here which I think perhaps both of you might want to comment on. And given the proliferation of all these different health apps and things using on our mobile phones, do you see a role for government to certify quality or some kinds of control over health apps? And has that been done in other jurisdictions at all?
Well, I certainly think that there's been some talk about trying to have a metric for quality, and there has been some stabs at doing that. I think it's a little bit difficult to do in terms of, again, the breadth of the different types of apps and the purposes of the apps. So, in terms of the different metrics, we actually are trying to kind of figure out what the broad kind of area. So in terms of things like usability, and if you can find out efficacy, that sort of thing. There can be some kind of framework around there. There hasn't been a lot, to tell you the truth, about doing that, and there's even been talk about, how do we regulate that in terms of the government, right? Like, are these health apps, are they medical devices, right? And sometimes, again, that kind of is a slippery slope, and again, it's an evolving question because things are changing. So if you talk to Health Canada, year by year, sometimes it changes, and then FDA comes in, and again, they might have a different definition of what is a medical device. So I'm not sure I'm answering the question, but it's actually a very complex thing to talk about. So I guess the short answer is that people are looking at this. There isn't anything that I know of right now that I would say is kind of like solving that issue, though.
Yeah. Kristen, do you have any thoughts on that?
Yeah, I agree with Emily. Here in BC, I know that we've been talking about it a lot, and sort of, that idea of, can we create sort of a clearinghouse of health apps and sort of look at it from a health profession and start, putting those stamp of approvals. But again, like, apps are just, they're complex. There's so many different layers that you'd have to, it's hard to kind of figure out what would that evaluation plan be, and to make it, sort of that stamp of approval or a credible app for someone to use. So it's nice to know that discussions are happening, but nothing has solidified as of yet.
Well, time for one final question from Jerry. He's asking, BCHLA, we've certainly been a strong advocate for the social determinants of health. Is there an opportunity for Carrot Rewards, or in fact for other apps, to share information and to increase awareness about the impacts of social determinants of health and potentially increase advocacy on social determinants of health?
I think so. Like I said, we have a huge health surveillance team here who are actually looking into, on a regular basis on the social determinants of health, and we're still trying to figure out what that model looks like. We haven't seen our first set of demographic data yet, but I think, we have, through the demographics, the gender, age, and postal codes, I think that we'll be able to gain a lot of insight to figuring out, what areas actually need more attention, because the users of the app are relating to, X number of, or the specific social determinants of health. So I think there's great opportunities to use Carrot Rewards in that regard. It's just, we don't know enough information yet to really figure out what that looks like from a reporting and planning purpose.
Right, and I would just add that certainly we here at BCHLA, we've had those discussions with you and the other partners involved as well, so we'll keep working on that. Unfortunately, we have to come to a close. I know we've certainly learned a lot today. I hope all those who've joined us have as well. Particularly want to thank Emily and Kristen. Thank you for sharing your research and knowledge. It's a very exciting time. Thank you to everyone in the audience for your attention and interest. So glad you could join us today. We're going to be following up with a short survey, so I hope you'll respond as that helps us to learn about the events, what's working, what we can do better next time. And as I mentioned earlier, the webinar will be on our website over the next few days, so you can come back and have a look at it. And we'll be continuing with our webinar series, so please watch your inbox for our next webinar, which is going to focus on active transportation. So again, we hope you will join us again. Thank you, and enjoy the rest of your day. Take care.